Hi everyone, my name is Veslemøy Guise and I am presenting on behalf of my colleagues from the SHARE Centre for Resilience in Healthcare at the University of Stavanger. I'm going to present a stakeholder analysis study that we're currently doing as part of a larger project on resilience in healthcare. Some quick context to this study is that it's part of the Resilience in Healthcare research program. And the study protocol of this is available in the BMJ Open, if you're interested in reading some more. But as a part of this program, there is a work package on patient and stakeholder involvement in resilient healthcare. And the aim of that part of the research program is to explore how patients and stakeholders contribute to resilient healthcare, and to develop, test, and refine a conceptual model of patient and stakeholder involvement and resilience in healthcare across different empirical contexts. And so doing a stakeholder analysis is a part of this work. So why do we have this interest in the role of patients and other healthcare system stakeholders in resilient healthcare? So just want to start off explaining this by giving you a definition of what a stakeholder is. So a stakeholder can be defined as a person or group that can claim ownership, rights, or interests in the past, present, and future activities, resources, and outputs or outcomes of an organization or system, or who are affected by those activities, resources, outputs, and outcomes. And stakeholders can be distinguished in various ways, but usually by how they relate to or interact with or within an organization or system. So we know that stakeholders such as patients and their next of kin, for example, are important co-creators of resilience in healthcare, but our knowledge of how, when, where different healthcare stakeholders come to facilitate resilience is lacking. So we need more research on who the different stakeholders are that contribute to resilience and how they are involved in creating and sustaining resilience in different contexts. So by conducting a stakeholder analysis, we hope to gain some new knowledge on the roles and relationships of stakeholders. So stakeholder analysis is a tool or approach used to identify who the important stakeholders are and how they act within an organization or system. And a stakeholder analysis can enable understanding of stakeholders' behaviors, intentions, interrelations, agendas, interests, and so on. And information from a stakeholder analysis can also be used to understand organizational context and to develop strategies for engaging and managing stakeholders within an organization or a system. So the aim of our study is to undertake a stakeholder analysis in a selected sample of empirical healthcare studies to identify and categorize stakeholders that are key to facilitating resilience in healthcare, and also to investigate and map stakeholder relationships of relevance to the enactment of system resilience. And what I really want to do for the rest of this presentation is to focus on how we are conducting our stakeholder analysis. And I'm also going to present some very preliminary findings from what we've done so far. First, a look at the study design. This stakeholder analysis is conducted according to the following multi-phase approach that you can see here. And that's based on previous work by Gilmore and Balin and Reed and colleagues. So the first phase here is to define the phenomenon of interest and to identify boundaries of the analysis. And the second phase is to apply a stakeholder analysis method. And this second phase is comprised of 3 steps, which are to identify the stakeholders, to categorize and differentiate the stakeholders, and to investigate stakeholder relationships. And then the final phase is all about recommending future activities and stakeholder engagement approaches based on the findings in the previous step. So in order for the stakeholders to be identified and categorized, we need a clear understanding of the phenomenon that we're interested in, and also to establish the boundaries of the analysis. And this is a key part of the whole process, because how this phenomenon of interest is defined can obviously affect which stakeholders come to be identified as relevant or not. So in the Resilience in Healthcare program, we use the following working definition of resilience in healthcare, which is the capacity to adapt to challenges and changes at different system levels to maintain high quality care. And in terms of the analytical boundaries, a central concept has been adaptive capacity, which, to make a long story short, often takes the form of system-wide performance adjustments, workarounds, trade-off, sense-making efforts, improvisation, and so on. And our analysis has also focused on identifying instances of performance variability, and not least the stakeholders that contribute to performance variability. So those are the boundaries of the analysis, very stated very succinctly. As for the data collection and analysis methods in the second step, in the second phase, sorry, I've tried to give you an overview here of what that looks like, because once the definitions and boundaries have been set, the next phase of the process is the actual application of the stakeholder analysis methods, and those three steps that you see here, 2A, 2B, and 2C. And as you can also see, the methods for each of these phases, each of these steps are slightly different. So what I'd like to do is to go into each of these now. I'm actually going to focus on 2A, identifying stakeholders, and 2B, categorizing and differentiating stakeholders. And that's because I haven't actually got very far in terms of investigating stakeholder relationships. I will say a little bit about that, but I'm going to focus on the other two steps in the following few slides here. So then the initial step is stakeholder identification. And this was done using a combination of interviews and analysis of written material, and was undertaken by a team of healthcare system researchers in our project. So we have used 19 empirical healthcare studies as our sample for data collection, and all conducted at the Share Centre, all from the Norwegian healthcare system by way of context, and also all with a broad focus on healthcare quality and safety. And empirical settings here include home healthcare, nursing homes, various hospital settings, transitional care settings, and also the regulatory and policy setting. And the data material consists of narratives based on peer-reviewed publications from 14 of the studies, and also 16 interviews with healthcare researchers involved in the studies. So a majority of 11 studies have represented in the data material by both a narrative and an interview. And then there are 3 studies that are represented by narrative only. And then there are 5 ongoing studies which are represented by interview only, because they have done data collection, but they haven't got any publications yet to use in the narrative part of the analysis. So that's the data material. What are the findings so far? Well, the groups of stakeholders look like this. 6 groups, quite low detail in these groups. So one of the challenges in this part of the analysis is what level of detail or abstraction to use. But as you can see, I've chosen to group them together in fairly broad categories here in the first instance, while of course acknowledging that there is a great variation within the groups, not least within health care professionals, you know, according to professions or clinical settings where they work. Obviously, different types of patients, groups of patients, different types of managers in terms of the system level where they work, or type of ward and service that they manage, and so on. But these are the large categories of stakeholders. And then the next step of the stakeholder analysis is to differentiate and categorize these identified stakeholders based on set attributes such as their position, their role, levels of interest, influence, power, relationships, and so on. And one fairly common approach here is to use an interest influence grid, like the one that you can see here, where stakeholders are positioned relative to each other according to their role and significance in relation to the phenomenon of interest, so resilient healthcare. And they're positioned as either subjects, players, crowd members, or context setters. So on this grid, the influence axis represents the stakeholder's capacity or power to influence the phenomenon. Influence is typically based on a stakeholder's ability to provide or withhold resources, to exert influence on others, or to access information, for example. And then the interest axis illustrates the importance that the issues has to the stakeholders. And this interest can, for example, be personal, political, financial, social, cultural, scientific, or a combination of those. And the point of using a grid like this is that by understanding where stakeholders sit on this type of grid, you know, placing them in a grid like this is central to developing stakeholder management strategies and ensuring good processes for stakeholder participation. You can see who you might need to engage more or less, or who you know, needs some can benefit from some collaboration with other stakeholders and that sort of thing. So then where do our stakeholders fall on this interest influence grid? All stakeholders have been placed on the grid relative to their influence on or interest in performance variability and adaptive capacity, but also in relation to each other. So patients and family have been placed as in the subject quadrant. So that means they have low influence of power, but medium to high interest. And this means that they have a high stake or interest in resilient healthcare, but have limited capacity to influence. And these stakeholders may have unrealized power, which may be activated through alliances with other stakeholders. For example, patients can, you know, up their influence by having family members advocate for them. So if patients have been placed further down the influence axis than family members, because family members can often be more active than patients in some cases, is what we found. Now, healthcare professionals and ward managers or service managers at the micro level have been placed as players, and they have medium to high influence and interest, as in they have both the ability to influence in resilient healthcare and the interest to do so. Then there are organizational managers at the meso level, and policymakers and regulatory investigators at the macro level, who are context setters, medium to high levels of influence or power, but comparatively low levels of interest. And that's, you know, compared to the players, essentially. And they may set the context and define the debate, or, you know, their position could be critical to outcomes, you know, in terms of the context that they set. But they are not active players in the issue to the same extent as some of the other stakeholders. And I haven't placed anyone in the crowd lot because there aren't really any that have low interest or low influence in this group of stakeholders. Anyway, it's important to remember that stakeholder analysis is an ongoing process, and that stakeholder positions may change over time, depending on various influences. contexts. And this is a preliminary analysis and will be further developed after consultation with colleagues and external stakeholders and experts as we move on in this project. So the final step is to then investigate relationships between stakeholders, and one approach to use there is what's called social network analysis, or SNA. And SNA is regarded as a useful approach in resilient healthcare studies to map or analyze the roles and positions of stakeholders and provide insight into the various dynamic relationships between people, groups, and organizations in complex systems such as healthcare. So, excuse me, I'm currently exploring a few options of how to do this part of the study, and will likely take a qualitative approach, which is useful when wanting to understand practices and roles, communication patterns, for example. So one approach that is of interest is the one suggested by Blanchett and James, which has been adapted to health systems research. It consists of 3 main stages, and the approach is largely about characterizing relationships based on an assessment of flows of information and whether there is a supply of or demand for information between actors or groups of actors. So it's looking at the flow of information between, you know, patients, family, healthcare professionals, managers. So we'll see what we can come up with in terms of mapping those relationships when we get to that part of the study. So the next steps are therefore to, like I said, finalize the analysis, and obviously including this analysis of stakeholder relationships, and then to, based on the findings, recommend some future activities and stakeholder engagement that's relevant to the next phase of the resilience in healthcare, of the overall resilience in healthcare program. So that's it. I'm really curious to see if you have any questions or comments or any suggestions. So please feel free to let me know. Thank you very much.